We could probably get started.
Get
Looks
started?
like
Yeah, I think we have a quorum.
good number of people.
Yeah. So I'll do the introductions. So good afternoon, everyone. Thanks for logging on for a very special virtual grand rounds today. It's with great enthusiasm and pleasure I get to introduce Dr. J. Radhakrishnan as today's speaker. Dr. J is a professor of medicine at Columbia University Medical Center and the director of clinical services of the Division of Nephrology. And I don't think it's possible to enumerate all of Dr. J's achievements in a brief introduction. He's co-authored over 275 original articles, case reports, book chapters, and writer reviews and editorials over the course of his illustrious career. But I'll give it a shot. He's the founding editor and editor-in-chief of Kidney International Reports and associate editor at Kidney International. He's been a committee member in the publication of several KDIGO guidelines on glomerular disease. He's been involved in the steering committee, more involved in the steering committee for a number of clinical trials in the field of glomerular disease. And he's a world-renowned educator in nephrology and has been the course director for many, many CME courses and conferences hosted at Columbia in general nephrology, hypertension, glomerular disease. On a personal level, I consider myself very lucky to have learned medicine and nephrology from Dr. J at my time at Columbia. He's a perennial nephrology fellow favorite. And always everyone's favorite nephrologist to round with. His clinical expertise is unparalleled, using a combination of evidence-based medicine, intricate understanding of pathophysiology, and really pushing the envelope on innovative therapies for all of his patients. So without further ado, let me hand it over to Dr. J to teach us all about diagnosis and management of thrombotic microangiopathies.
Thanks, Yoni. Thanks for those kind words. And yeah, we go back a few years and we've kept in touch. So Yoni asked me to speak about this topic. It's becoming increasingly common, as you'll see, as we round on the floors. We'll not uncommonly see patients with the diagnosis of TMA. And a lot of times it's not just a diagnostic challenge, but how best to treat it is also equally sometimes confusing. So I'll take you through the diagnosis and management of this group of disorders, TMA. And the most challenging part is to diagnose the underlying mechanistic basis for TMA. And I'll spend some time on that, and then we'll dive into the distinct clinical syndromes with respect to diagnosis and therapy. So it's hopefully a 45 minutes or so, and then we may have time for some questions. So at the very basic level, all the action is here at the level of the endothelial cell. And let me get my pointer. Yeah. So, a messed up endothelial cell essentially will detach, and remember the endothelial cell is important to maintain the, it's essentially a natural, it has a lot of natural anticoagulants. So when it detaches or gets damaged, platelets first adhere to these cells, and then fibrin comes later because you get local activation of the coagulation cascade. There's initially partial occlusion where the red cells passing through will undergo shear stress, forming schistocytes, and eventually it'll completely occlude. And the organ that is supplied by these microvessels will get dysfunctional. So why does it happen? There's usually some sort of a genetic or host predisposing condition. It could be genetic or acquired, for example, an autoimmune disease. And there's almost always a trigger on top of this predisposition, which then precipitates damage to the endothelial cell, leading to all its subsequent events. So the diagnostic criteria, if you will, is that everything begins with the deposition of fibrin in the microvasculature. We mentioned shear stress on RBCs. We call this microangiopathic hemolytic anemia with schistocytes, LDH elevation, anemia, of course, and then haptoglobin drops. Thrombocytopenia, you can define this either as below the low limit of normal, or if you have a baseline, there's at least a 25% drop from the baseline. And then you can have neurorenal or GI, which are the predominant organs which undergo dysfunction. And very importantly, one needs to rule out a coagulopathy like DIC to firm up this diagnosis. So what is also important is that you may see patients who have kidney dysfunction and proteinuria and have no signs of hemolysis or low platelets. And all the action is essentially in the kidney itself. So we call this renal limited TMA. And I'll spend a minute just talking about this entity because especially in nephrology, we see this not infrequently. And how do we sort of classify this? There are various classifications, but this is something that I use. And it's divided into what's called primary. Primary meaning that there is a distinct, well-defined pathogenic mechanism which is not associated with a systemic disease. So the most classic is sugar toxin associated TMA, which is also called hemolytic uremic syndrome. What we all call atypical HUS, which is complement mediated, is an emerging disorder. Well, it's getting increasingly recognized because there are specific therapies. It could be inherited or autoimmune. We'll go into quite a bit of detail on this. And then there's a deficiency of ADAMTS13. It's a serine protease, which breaks down von Willebrand's factor. And we call this TTP, or thrombotic thrombocytopenic purpura. Again, autoimmune or inherited. And there are rare variants which can cause endothelial dysfunction, which are now sort of easily detectable through targeted gene panels. Okay, then we come to assorted systemic diseases. And these can cause endothelial dysfunction either directly or they may be superimposed on one of the etiologies on the left. But pregnancy or postpartum, it causes endothelial dysfunction, and there are 3 or 4 disorders that are very specific to pregnancy. There's an increasing number of drugs that cause TMA, transplantation, both solid organ as well as bone marrow or stem cell. Autoimmune, the list is big: scleroderma renal crisis, lupus, C3G, and sometimes with IgA nephropathy as well. And then there are infections like pneumococcal pneumonia, HIV, and of course, you've seen this in the COVID pandemic, as well as some strains of influenza are particularly predisposed to causing TMA. And then we can see this with malignancy, disseminated cancer. And now it's being recognized that monoclonal gammopathy can be associated with TMA. And in fact, giving clone-directed therapy can quieten down the TMA alongside other treatment options. And then there's also a group that we don't know the cause, and we call this unknown. We've done an extensive search. And as you'll see, many of these are presumed to be the complement-mediated TMA. So by a process of exclusion, we may not find a cause, and many of them are thought to be from a disordered complement regulation in the system. Just give me 1 second here. Okay. Okay, so we'll start with a case just to put everything in perspective. This is a woman I'd seen many years ago. At that time, she was 40 and had her first child, and was completely healthy prior to this. And on the day of delivery, her blood pressure shot up from 110 to 140. And then post-delivery, she began to experience nausea, headache, severe abdominal pain, and her blood pressure went all the way up to the 180s. And the lab showed elevated creatinine, which is completely normal before. She's had a dropping hemoglobin, platelet count, LDH was sky high, and she has cystocytes. So a rapid diagnosis of TMA was made, and then ADAMTS13 was sent, and the level was 25% were normal. And despite blood pressure control, the kidney function kept worsening, and she, in fact, developed PRES, posterior reversible encephalopathy, and seized. So the question was, what does she have at this point in time? And we looked at some diagnoses in the previous slide. Is this preeclampsia, eclampsia, a little atypical, delayed? Is this TTP? Is this sugar toxin associated TMA, which is HUS, or is it a form of atypical HUS, or is this all malignant hypertension causing the TMA? And so I'll take you through some of these diagnoses in the subsequent slides just to work through this very, very difficult patient. So just from a point of view of what causes TMA? And this is from a study from Europe. There were two centers. There were over 300 patients who were admitted after their first TMA episode. And if you look at the categories, the primary, which is HUS 15%, TTP 9%, and SHIGA 21%. So they constitute about 45%. Okay, so this category, which is very easy to define once you have all the tests back, is about little less than half, but secondaries are by far a little more common. And you can see the single biggest category is organ transplants or stem cell transplants. And then a smaller proportion present with malignant hypertension. And when everything else is ruled out, the feeling was this was all from malignant hypertension. In terms of outcomes, you can see the HUS and the TTP, they do have a significant incidence of death or kidney failure. Shiga toxin does quite well, and the secondaries don't do well at all. So, and that probably is especially in the bone marrow and organ transplant, this is a real problem, and one should really know how to manage these patients right from the point of presentation. What is also very important is that the chances of finding a genetic variant, a pathogenic variant in secondaries is very, very rare compared to atypical HUS, where about 50 to 60% will have a clear pathogenic variant. And then coming to renal-limited TMA. So this is a biopsy series of over 700 patients who had a kidney biopsy showing TMA. And of this, about half had renal-limited TMA, and the others had the classic hematological and renal TMA. So if you look at the causes, you cannot differentiate. They're all the same underlying causes. But what is very important is that if you take the renal-limited TMA, where you would call this HUS, the use of complement inhibitors was very, very low. And that is important to recognize because the treatment of choice and the first treatment should be a complement inhibitor in 2025 once you make a diagnosis of atypical HUS or complement-mediated HUS. So here's a workflow, if you will. So if you make a diagnosis of TMA, which is thrombocytopenia and microangiopathy, and you've got one organ dysfunction, the first thing is obviously to rule out the typical, what we call the secondaries, which you saw in the right-hand portion of the slides of the classification, autoimmune infection, pregnancy, etc. And we need to send some testing. I'll tell you what these are. But ADAM-TS13 is very, very important because I'm going to say this many times. Amongst all the causes of TMA, this can be rapidly be associated with irreversible organ damage, especially strokes and mortality. So amongst all the cases of TMA, this is a true medical emergency. And we have to start treatment empirically, and I'll tell you what the scores are, which will help you predict deficiency of ADAM-TS13. Most times there's no time to get a genetic testing panel or in-depth complement testing. So that can be reserved for later, but one should not stop and see what the cause is. Okay, so these are some of the tests we would normally send in a patient with suspected TMA, or at least with a clinical diagnosis of TMA. So a PCR stool for Shiga, an estimate of and these are commercially available, plasma C3 factor H, factor I, and anti-factor H antibodies, right? So levels of these alternative pathway complement components, as well as the antibodies to factor H. All patients should get an ADAM-TS13 panel, and I'll tell you what the components are. From the autoimmune workup, lupus and anti-phospholipid antibodies should be looked for, and in people over the age of 50, a monoclonal gammopathy workup should be done. Okay, so let's discuss a little bit on the primary TMAs. So if you look at Shiga toxin, hemolytic uremic syndrome, it's commonly seen in the setting of an outbreak, and the typical organism is what we call enterohemorrhagic E. coli 0157, and the recently described 104H4, and of course Shiga dysenteriae. So you get diarrhea, and about a week later, you get this explosion of clinical signs, which suggests HUS. These patients have severe kidney injury, which is a defining part of this syndrome. And in fact, half of them require renal replacement therapy. And despite resolution in the majority, there may not be a complete kidney resolution with CKD and hypertension seen a year after resolution of the hemolysis and so on. See, the pathogenesis has been worked out very well. You absorb the STEC, which is Shiga toxin E. coli. It goes to the intestines and it releases the toxin, Shiga toxin, which through a specific receptor GB3 enters the cell and causes inhibition of protein synthesis and apoptosis. And as a consequence, there's local release of cytokines. The toxin also enters the circulation, and in certain individuals, it's not clear why, but it also binds to the same receptor on endothelial cells, causing endothelial disruption and activation of the fibrin as well as coagulation cascade, with inflammation leading to HUS. So this is the mechanism that has been very well worked out. The management in 2025 is still supportive care. So transfusions for hypertension, the drug of choice is calcium blockers and dialysis support. It's in the German epidemic about a decade ago, they used plasma exchange and eculizumab. And in an observational manner, they said probably if you have CNS involvement, the course is much shorter and there's better recovery, but this has not been tested until recently. So I'll tell you the data in the next slide. And of course, there's no advantage of using binding agents for Shiga toxin, and especially antibiotics and anti-motility agents. So this is the only RCT. It was done in children. And they looked at using eculizumab versus placebo, 50-50 in each group. And the primary endpoint was limiting RRT to less than 48 hours. And the secondary was the CKD hypertension proteinuria endpoint at 1 year. So you can see primary endpoint, there was a trend towards lesser events in the eculizumab group, but not significant. And there was a significant less number of events in terms of CKD hypertension and proteinuria at the end of 1 year. So short term, no difference. Long term, yes, there seems to be some mitigation. So probably we would reserve eculizumab in the most severely affected patients, for example, especially with CNS involvement, based on the German series. But most patients, young people with HUS, can be managed conservatively. Now comes the dangerous TMA, which is the ADAMTS13 deficiency TMA, TTP. And the way ADAMTS13 works is this is the endothelial cell, and you have this serine protease called ADAMTS13, which is on the surface. The von Willebrand multimers are secreted by the endothelial cell, and it's a large fragment. You can see it's waving. And this serine protease, ADAMTS13, cuts it into smaller fragments. So if you do not have this ADAMTS13, then these large fragments float around, and if there's any trigger which leads to platelet activation, it's going to bind to this long fragment and then lead to a progression of events leading to a platelet-rich fibrin plug being formed at the surface of the endothelial cell, and all the signs of TMA that subsequently happen. So why is ADAMTS13 low? So the definition is if you send a test out, under 10% is diagnostic. So between 10 and 20, it's a maybe, and clinical correlation is recommended as with everything else. But under 10, it's diagnostic. And why should it be this low? It could be inherited because of lack of an enzyme, or it could be autoimmune, where there's an autoantibody towards ADAMTS13. What defines the TTP syndrome is that the platelets tend to be extremely low, typically below 20%, and CNS symptoms, including stroke, predominate, whereas kidney failure is very, very, very uncommon. So as nephrologists, we do not see this commonly. So the outcomes, if you're untreated, has got a 90% mortality, and even with current therapy, there's a significant death rate. And this is the point that I'm trying to make right here, is that death happens very quickly in the absence of treatment, and or especially if treatment is delayed. If you are able to treat with current therapy, you don't have a 100% response rate, but it's a very, very high response rate. But even while in therapy, you may get exacerbations, and a significant number of these patients will relapse. So the way we send out and analyze ADAMTS13 is we look for the level of antigen, we look for the activity and an inhibitor. And if you look at congenital TTP, where the enzyme is absent, the level of antigen is very low or absent. They have no activity virtually, but there's no inhibitor. And that's what separates congenital from acquired, is that you do get the presence of an inhibitor, and you may still see reasonable amounts of antigen because it's basically there, but it's bound to the antibody. And of course, if your levels are over 20 or 30%, it is not, that rules out essentially TTP related to ADAMTS13. Now, this is the, in adult TTP, what is the underlying mechanism? So autoimmune by far is the most common, okay? And in most patients who have an autoantibody to ADAMTS13, 60% won't have any underlying disease, whereas autoimmune disease, infection, pregnancy, etc., may be associated with the autoantibody. Whereas there's a unique situation. If you see TMA with a low ADAMTS13 in pregnancy, most likely it's going to be from genetic, and the pregnancy acts as a trigger to unmask the low levels of the ADAMTS13 enzyme. So once again, these patients in whom you're suspecting TMA should get the entire panel of ADAMTS13 to understand if it's an antigen lack or is it an autoantibody. So this is a key slide, and once you make a diagnosis of TMA, the important thing is to see if this patient would qualify for TTP therapy, which should be done the moment you suspect the diagnosis. You don't need to wait for the levels. So what are the predictive factors that will tell us this patient likely has TTP from a low level of an ADAMTS13 when the antibody is not available? So the easiest score is something called the French score. And if you have a relatively intact kidney function, and here the cutoff creatinine was less than 2.26, you get a point. If your platelets are really low, below 30,000, you get 1 point. And for some reason, you've sent an ANA and it's positive, you get 1 point. There's a slightly more complicated score, and you would need a calculator. And you have a bunch of things, platelet count less than 30, just like here, a variable hemolysis, no cancer, and rule out transplant. You have an MCV that's low, INR, which is intact, and a creatinine under 2. You get 1 point each. And for each of these scores, the prediction is that if your score on the left is 2, so 2 of these 3 is positive, you have a 90% chance. So it's a quick and dirty. You can say yes, likely TTP, or unlikely TTP. And on the right, if you get 6 to 7 points, it's highly predictive of an underlying TTP. So once you made a diagnosis of a presumed TTP with these scores, then the next step is to start plasma exchange and steroids. So this is unequivocal. The moment you make a diagnosis of this condition, you have to start plasmapheresis and corticosteroids. And then what next? So in most patients, that's not enough. And the current standard now, based on not a controlled trial, but an observational study, showed a remarkable difference in outcome when rituximab was combined with plasma exchange and steroids. And then the third development was this specific drug. It's a targeted therapy called caplacizumab. And the way this works is, if you look at this long, ultra-long 1 Willebrand factor strand, you can see that platelets have binding sites on this. And ADAMTS13 basically cuts these so that there's less of a chance of platelets to bind. But if you were to give an antibody, caplacizumab, which engages these binding sites, preventing the platelet VWF interaction, the propagation of this TMA is going to be arrested. And this was the Hercules trial. And you can see, although it doesn't look different, but you look at the composite endpoint, this is the platelets on the right. If you look at the composite endpoint of death, recurrence, and a major thromboembolic event, there was a 74% reduction, which is pretty big, and a much shorter time to normalizing platelets, which you can see here. It doesn't look great, but I think what's more important is propagation of this TTP event, and much less relapse, 0 versus 3 refractory disease, and the lesser need for plex and shorter hospitalizations. The only thing one must remember is that since you're inhibiting platelet VWF interaction, there is a bleeding risk, and this drug should be used carefully or not at all in people in whom you have deemed to be a bleeding risk. For example, people in whom you cannot stop anticoagulants, say for a prosthetic valve. All right, so the next step then is once you have ADAMTS13 available or not, we have these two drugs, okay? So if your ADAMTS13 is available and it'll be reportable, we generally start caplacizumab, and if it's positive, you could add rituximab right here. So your levels are under 10. If your levels are under 20, there's no need for a specific TTP therapy. You can stop the caplacizumab. And if you're borderline between 10 and 20, you got to use clinical judgment. If ADAMTS13 is not available, it's best not to use caplacizumab, but you could add rituximab. So this is the ISTH guidelines on the current management of TTP. Now coming to the more, I guess, classic TMA, which is atypical HUS, where this is seen not uncommonly in the nephrology service. And just to refresh the complement pathways, the two main pathways are the classical on the top and the alternative pathway, and they both feed into C3 convertase, which is composed of C3, factor B, and factor D. So this is a self-activating complex, and it is inhibited normally by factor H, I, and CD46, also called MCP. So in patients with some dysregulation of this pathway, either because you don't have the inhibitors, or if C3 is, there's a gain of function mutation, for example, or there's a lack, or there's a same gain of function mutation in factor B or D, you could have a revving up of this system, leading to the generation of C5 and the membrane attack complex, which causes damage. So if you look at the overall epidemiology of which components of this complement system are present in your complement-associated TMA, HUS, about 50% will have a pathogenic variant, and in children especially, you can have up to 20% of children presenting with an autoantibody to factor H. But by far, complement factor H is the commonest pathogenic variant that you see with atypical HUS, with the lesser contribution from the other complement factors. So I won't go into the genetic testing, but what's become very easy is that you can actually send a buccal swab or a blood sample to a laboratory, and you can actually get the results back within usually 2 to 3 days if you need it urgently, or definitely within 2 weeks for genes that are associated with TMA. And all patients should also get a factor H antibody, which is not commercially available in some of these labs as well. So this really has elevated the discovery of pathogenic factors associated with atypical HUS. Now comes the conundrum. Patient has come in with malignant hypertension, and the platelets are low. There's signs of hemolysis. There's some schistocytes. Is this all from malignant hypertension, or is there an underlying AHUS or HUS even? So a few points, and the fact is that hypertensive emergency is seen in more than 50% of atypical HUS. And the so-called non-atypical HUS may also lead to TMA. So if you have someone with malignant hypertension, about 15% have classic HUS findings, sorry, I would say TMA findings. And then especially when there's IgA nephropathy, these patients may come with an hypertensive emergency and have signs of TMA. So this is the sort of conundrum that we face when someone comes with very high blood pressure and there's signs of TMA. So there's a group that's not fully accepted, but this is very useful in our mind in trying to separate patients who have an underlying HUS from just a common garden hypertension, malignant hypertension, associated with TMA. So the things that are strongly positive. So here, if you're younger, especially if you have a family history of atypical HUS, and there's no prior history, so there's a first-time presentation, you know the blood pressure is normal a month or a year ago, and they come in with malignant hypertension, that suggests that there's an HUS underlying. There's no LVH, for example. If you're requiring dialysis, very uncommon with malignant hypertension, and you control the blood pressure, normally with malignant hypertension, everything starts quietening down within a day or at the most 2 days. Platelets normalize, your LDH returns towards normal. Not the case with atypical HUS, it keeps going. And if you see a low C3, again, highly suggestive of AHUS. And then over follow-up, patients discharge and say had a kidney biopsy, there's no thrombi whatsoever. That goes against malignant hypertension. I'm sorry, that goes towards malignant hypertension, because most HUS patients will have microthrombi. And again, signs of your typical accompaniments of atypical HUS, if it's positive, low C3 factor H or factor I levels. So all these will suggest atypical HUS. So in my mind, I think that lack of hypertension, no LVH, and requiring dialysis is highly, highly suggestive of AHUS. There are well-known triggers: infection, surgery, autoimmune, and pregnancy. And what is important is that you may have a genetic variant. You just need one copy to set off HUS. And the reason why many people in the family who have the variant do not express it is likely because of a lack of these triggers, right? So you may have no family history or a spotty family history of when there's a genetic variant that's being transmitted. So the penetrance is not 100%. So infection, surgery, autoimmune disease, and pregnancy are all well-defined triggers for AHUS. So the one-liner is that if you make this diagnosis, and it's done basically by excluding everything else, is that you need to start C5 inhibition ASAP, okay? Because plasma exchange and plasma infusion is generally not that effective, with the only exception being that if you have a factor H antibody, they should be plasma freezed. And that's, again, rare. And that's the reason why we almost always start with plasma exchange, because most hospitals don't have eculizumab on formulary. You need to get it, usually takes a day. But we start with plasma exchange in most patients, despite the lack of long-term efficacy. So eculizumab has changed the whole landscape for treating HUS. And the way it works is it blocks complement factor 5. So whatever is happening upstream with the alternative pathway comes to a standstill when you block the C5, so you cannot progress further into producing the membrane attack complex and causing hemolysis and damage to the endothelium. So this was an uncontrolled study. All patients received the drug. And there were two trials, trial 1 and trial 2. Trial 1 was progressive TMA, where the endpoint was normalizing the CBC for 4 weeks and the change in platelet counts. Trial 2 were people who are on long-term Plex and plasma infusion. And again, the same normalization of CBC was the primary endpoint, but here you needed a TMA-free status as well. And just to cut a long story short, you get a rapid normalization of platelets in the majority of patients treated with eculizumab. And in fact, patients also see an increase in GFR very, very quickly, up as early as 2 to 4 weeks after starting the drug. And this is for the short-term trial. And the long-term trial, you can see patients' GFR is right here. And even on long-term apheresis, you can see an improvement in GFR. In fact, you can see patients coming off of dialysis as late as 2 to 3 months. Proof of concept is you get a complete diminution of complement factor CH50 levels, which shows suppression of the complement pathway. There's a long-acting version of eculizumab called ravulizumab. Eculizumab is every 2 weeks. Ravulizumab is every 8 weeks. So it is more convenient for patients with, there's no head-to-head trial, but it seems to do the same thing. So it's a very expensive drug. drug costs about $500,000 a year, so extremely expensive, and it's not available, obviously, worldwide. But the question always comes, can we discontinue the drug in selected patients? So what's been shown is that if you have the rare variants that has been documented on a genetic panel, or if you have the method of measuring membrane attack complex, which is soluble C5b through 9, it's likely that these patients cannot come off therapy, as you can see in this slide. So if you have rare variants right here, they don't do well at all. You cannot stop the drug. So in the maintenance phase, once a patient leaves the hospital on eculizumab, there are a few things we need to address. One is, can they stop, okay? Or do they need to be switched to the long term for convenience? And then what do we monitor? So if you've done the genetics and you've done, you do not find any pathogenic variant, it's reasonable to discontinue and monitor very closely, especially in the trigger events of infections and surgery. If you see a pathogenic variant, the question is which one? So factor H, C3, and CFB, unlikely they will be able to come off the drug, and they should stay on this forever. If your MCP and CFI, which are milder variants, you need to look at them case by case. And if you do decide, please involve the patient, because many of my patients say there's no way I'm going to stop the drug after what I've been through. And of course, if you have the means to test for C5b through 9, that could be another reason why you would not start the drug. And it's very, very important is if the patient is infected, say, including with meningococcal infections, which you know is 2,000 times more common if you don't prophylax, do not stop the drug, because that will trigger another relapse. Okay, so anti-factor H antibody is rare, and it's mainly seen in young people. And for a variety of reasons, it's associated with the deletion, homozygous deletion for CFH-related protein 1 and 3, which can be seen in healthy people without any consequence. Again, the treatment is some combination. We always start with PLEX and C5 blockade. And if we find factor H antibodies, most of these patients will require immunosuppression to bring down the levels of autoantibody. And then you could take away treatment depending on your lab when the antibody levels go low. So a small subset, but needs to be looked for because treatment strategy is quite different. Meningococcal vaccine is extremely important. These are the updated ACIP guidelines. And you need to vaccinate against ACWY as well as B. And they have a completely different schedule. The immunity towards B is much less profound compared to A. And in patients, and to be underscored is that all patients will not respond. The response rate is about 85%. So many of us use lifelong antimicrobial prophylaxis with either penicillin or with azithromycin, especially in situations where the patient's being immunosuppressed for other reasons. So now, towards the end of this talk, we'll go over secondary TMAs. And the 3 TMAs which are unique to pregnancy, preeclampsia, acute fatty liver, and HELP occur late, and they improve on delivering the fetus. ADAMTS13 TMA, TTP, occurs early, and again, no effect on delivering the fetus. And complement TMA is postpartum. We saw that it comes with renal failure. And again, no effect on delivering the fetus. So this is an important differential diagnosis when you see patients in the setting of pregnancy coming with a clinical diagnosis of TMA. Drug-induced TMA, again, is being increasingly seen and rarely immune-mediated, which is quinine, but more commonly, it's from direct toxicity to the endothelium, which is, for example, gemcitabine. So you can see the 2 categories. Quinine is by far the commonest, and in terms of cumulative toxicity, mitomycin, both cyclosporin and tacrolimus in the transplant situation. One very important differential in drug-induced TMA is VEGF inhibitors versus other chemotherapy. So this is the podocyte in the kidney, which produces VEGF, and VEGF goes across the GBM and ligates to a receptor on the endothelial cell, and it promotes cell adhesion and survival. So if you knock off the VEGF using all the drugs we use for metastatic, say, renal cell cancer, the endothelial cell can be deprived of this important survival factor. And very commonly, it gives rise to, not, I wouldn't say commonly, but uncommonly gives rise to TMA, which is very classic and can be renal limited. You don't see this system-wide, but only in the glomerular capillaries because of this reason, proximity to the podocyte. Now, that's completely different from the type 1, what we call the direct cumulative toxicity. For example, from mitomycin and gemcitabine. This is delayed, whereas VEGF can occur anytime because it's cumulative. And the important point is the clinical course is completely different. Type 1 is completely bad. It's permanent, high probability of recurrence. You get widespread thrombi and a very high mortality. With the VEGF, it's reversible. You stop the drug, it goes away. And you can actually re-challenge them. And it's almost exclusively within the glomerular capillaries for the reason I mentioned. And the patients do quite well, especially because you can re-challenge the majority of patients with careful monitoring. The treatment is not standard, but by and large, withdrawal of the drug as far as possible with reintroduction with, in the case of VEGF inhibitors. Everything else is, there are case reports which suggest they might help, but it's not been codified, and we do not recommend them really. Okay, so last one word about monoclonal gammopathy. I'm just going to say it's an association, and in patients who clearly have no other cause for a TMA and have a monoclonal spike, one may consider clone-directed therapy, and this becomes a form of MGRS, monoclonal gammopathy of renal significance, where they would not meet criteria for, say, a myeloma or a B-cell neoplasia in terms of chemo, but you might consider treating these patients if they have ongoing TMA in the absence of any other condition. A word about antiphospholipid antibodies. We know this causes large vessel thrombosis. It's also been associated with small vessel vasculopathy. But there's a small subgroup of patients, typically with CAPS, get catastrophic antiphospholipid antibody syndrome, where both experimentally and in patients, you can see activation of the complement system. And in these patients, other than giving immunosuppression and plasmapheresis, one may consider a C5 inhibitor like eculizumab to quieten the disease. And it's been shown that it does work in this situation. TMA and systemic sclerosis occurs typically in the setting of acute or subacute worsening of blood pressure and skin lesions. Proteinuria is usually very mild, and you can see very classic onion skinning, which leads to ischemia of the glomerulus and progressive renal failure. So steroid use has been associated, and most of these patients have a higher preponderance of being positive for RNA polymerase III. And thus far, the only treatment is ACE inhibitors. Eculizumab and other C5 inhibitors are not effective in this situation. When you come to hematopoietic transplants, there's usually an underlying predisposition, which could be racial or genetic, but very commonly conditioning with bone marrow agents, especially CNIs. And then the second hit is the direct endothelial injury, which is commonly seen with most conditioning regimens. And then the third hit is complement activation. This can happen because of drugs, GVHD infection, and antibodies. So we go through a systematic process to rule out all these conditions. But this is the only situation in secondaries where once you rule out everything and the TMA is ongoing, we would suggest using a complement inhibitor. And many of these patients do actually quite well after addressing the primary hit as well as adding on eculizumab. So back to our case. So what do we think she has? So is this preeclampsia? Unlikely, because it occurred at the time of delivery and persisted. It is TTP, not really. Her platelets are not low enough. And the Adam TS13 was above 20%. This is not sugar toxin. Most of them have a dysentery. This is not malignant hypertension associated. We saw that she was normotensive, and despite controlling the blood pressure, she's actually getting worse from the point of view of TMA. So by ruling out a bunch of things, it's likely going to be atypical HUS. So once again, we've made the diagnosis of TMA. We've checked the ADAMTS13 antibody. We've looked at STEC HUS, ruled out. We ruled out a systemic condition. And now we left out as a rule out complement mediated or TMA or AHUS. So this is the slide. I think hopefully it'll put everything into perspective. You made a diagnosis of TMA. You rule out a secondary condition or ruled in. And if it's present, specifically treat them for this. The only time you would consider eculizumab is perhaps in the setting of a bone marrow transplant and with antiphospholipid associated CAPS. If you're STEC positive, blurry diarrhea, that's probably HUS, and supportive therapy is all you need. Maybe in the most severely affected patients with neurodysfunction, you could consider PLEX and eculizumab. If these are negative, one must immediately do the French or the plasmic score to rule in or rule out TTP. So if you've made a diagnosis of TTP, start PLEX and steroids right away. And once you've got the, depending on if the ADAMTS13 level is available, you can also consider disease-modifying therapy with caplacizumab. If the PLEX or the French score, the French or the plasmic score is negative, and you ruled out all these other conditions, it's likely going to be AHUS, and then a complement inhibitor should be added if it's not been added at this point. So one word in follow-up of this patient, she was started on PLEX, but despite improvement of the hematological parameters, she went on to need dialysis, at which point PLEX was stopped. A living donor transplant was performed from her husband, and unfortunately, 1 week after transplant, there's a recurrence of TMA with partial improvement again in the heme and renal parameters with PLEX, but by no means in remission. Luckily, we had the eculizumab protocol that was available, and she enrolled in that, in fact, had a factor H variant. On eculizumab, PLEX was able to be stopped with complete normalization of heme parameters and kidney function. And 12 years later, to this date, she's in remission with no recurrence of TMA on eculizumab. So that, I think, was my last slide, and thank you very much. I think we have a few minutes for questions. Yeah.
Thanks so much, Dr. J. That was excellent. If anyone has any questions, if you put it into the chat, I'm happy to read them. Or if you prefer to ask yourselves by raising your hand or just unmuting yourself, that also works too. I guess I'll start with a question. I find, like, as you alluded to, one of the more difficult situations is when you have patient where you really don't know much about, who comes in with a hypertension out of control, very high creatinine. You control their blood pressure enough to do the biopsy because the kidneys look okay, and then you see TMA, and then you're stuck with malignant versus complement mediated HUS, assuming everything else was okay. And you had mentioned that score. Is there like a number in that score that says I'm thinking more, or is it just sort of the whole gestalt thing saying no LVH, eyes are okay, let's do it and wait till the genetics to come back?
Yeah. So I think the score is just, and there's from a nice review article by Fadi Fakouri, he's one of the leaders in this field, and he said, look, this is what I use, right? So, and it's not sort of been
Not validated.
externally validate and do a lot of things before you make it into a score. But this is just a guideline, and
yeah, we shouldn't think of it as like the plasmic score.
Exactly. So
yeah.
It's not yet reached a point where it's available for clinical practice. You put in a calculator and say yes or no, right? The point is that mostly they're clinically available, and if you come with advanced kidney failure and you have LVH and you have signs of a patient had been on antihypertensives a couple of years ago and had not taken the drugs, I think that's pretty clear cut. And the best is you control the blood pressure, everything quietens down. And you have a strong case for just malignant hypertension, right? And because it's long-standing and it's acute.
Yeah.
But on the other hand, if you have someone like this patient that presented, and she says she's not pregnant, she comes in, into the hospital with press with blood pressure 240 over 140 and no LVH. There's no signs of any other end organ damage, and you control the blood pressure and things don't look right, despite blood pressure control, that's AHUS. And within 24 hours, you should see restoration of hematological indices. And you'll never see such advanced kidney failure if we know that her baseline creatinine was normal. So that's a very, very tricky situation. But I think that little, I wouldn't say score, but that little table showing the yes and no's, what suggests and what doesn't suggest AHUS is very, very useful, at least in clinical practice.
Thank you. Dr. Agwal had a question. He said, Dr. Radhakrishnan, excellent review. Do you have a preference for a particular lab? I assume talking about genetics and maybe the factor H levels and factor I levels, et cetera.
So without being too commercial, okay, sorry, but there are two labs, there are three labs. There's University of Iowa, right? There's the MACHAON, Machaon, and there's one more, I think, in Colorado. I think it's the Jewish hospital labs. Increasingly, we have gone towards the Machaon because they'll give a comprehensive diagnosis very, very quickly. You can just check the boxes. You send the problem is reimbursement, because you'll have to work with the hospital, and in our system we don't have a way to sort of do this quickly, because these are expensive and the hospital doesn't want to take on add-on tests. But if you work with the hospital as a send out, they'll get the results to you very, very quickly. And you get the genetic as well as the factor H. They also do a ex vivo C5bH9 test, a C5b through 9 test.
So they do it all together, because I feel like,
Yeah,
correct me if I'm wrong, Iowa, you have to separate it out.
Yeah.
Yeah.
So that's I think the easy way to do it, right?
Oh, Penelope has a question if you want to unmute yourself. Dr. Kapitsuno.
Yes, thank you. Fantastic presentation. Really learned a lot. I was wondering, what do you think about really the unknowns in terms of genetic drivers? The fact that only few patients, for example, for the VEGF therapy, they develop TMA. Does it make sense that maybe there is an underlying genetic predisposition? Does it make sense to send genetics on these patients? Or, what about discovery of novel drivers? Do you think that we are going to see more mutations, coming in the landscape?
No, great question. So if you look at the, there was a slide I showed about secondary versus AHUS, right? And if you look at the known drivers, only 3% of them had an underlying known genetic mutation versus over 50% in primary AHUS, right? So the problem is that we are knowing a little bit more about the unknowns. And you can see even in the eculizumab, it's not 100%. And these are people who have ruled out everything. So 20% of people who are on eculizumab don't respond, right? So clearly there's other drivers, right? And some of them could just be it may not be genetic. It may be an acquired, a change in your endothelial responsiveness. Say you get a bad flu and things change at the level of the endothelium, never to come again, right? So it's a very complex story, but I think the only way you can see is you can keep looking again and again to especially if you have a family history and you do the proband analysis and a triplet, and you can see that likely there's a gene which is a VUS has now come to be important as a likely pathogenic variant. So this discovery is going on, and it's not happening as rapidly as we would like. But your DGKEs, in the Formin, they're all coming up as being ultra rare, but it's being associated. But it's a great question. But I think what the underlying hypothesis that if you rule out everything, whatever the cause is, complement seems to be very important in propagating the TMA, and to varying levels, right? So it makes sense that once you rule out and you call this sort of idiopathic, you could still try the complement inhibition. And if it doesn't work and you'll know it in 2 to 4 weeks if it's going to work or not. If it doesn't work in 2 to 4 weeks, you can stop it, right?
Terrific. If I could just ask you to comment on something, Jay, thank you very much for making the time and for educating all of us. And as a leader in continuous medical education, can you give advice to all of us how to stay on top of some of what you presented? I'm just reflecting on the fact that a lot of the slides and the content in your presentation came out after I finished fellowship. So how do you stay up on top of all of it and maintain the same comfort level with the new information as you did, let's say, during your clinical training?
Well, we got one excellent resource, the Columbia CME conferences. But I think there's other sites which do you can plug into ViewMedi, and I mean there's a lot of content now that's freely available on the web, and the best stop is guidelines. So a bunch of societies publish guidelines on managing rare diseases, and it keeps getting updated. For example, the KDIGO. KDIGO doesn't have a guideline on AHUS because it's more of a hematological. I mean, it's a turf thing. But ASH has the how I treat category in blood, which is a very, very useful clinical hands-on kind of approach, right, for diseases like this.
Perfect. Thank you very much.
Does anyone else have any questions? I know we're at time. Oh, yeah. Dr. Enriquez has a question.
Hi, excellent talk. As a renal pathologist, one of the challenges that I see is reporting. Because I don't have the whole clinical pictures most of the time, it's hard for me to tell if your patient is having renal limited TMA versus full-blown clinically, thrombotic microangiopathy. What is your experience when you receive a report like that? I tend to steer away from using the term thrombotic microangiopathy in my reports because of this reason, and I prefer to use a more general term that is acute endothelial injury, and open that possibility of this renal limited presentation.
Yeah, that's a great point. So the one-liner, I think if you look at the KI article, which just came out, and there was a slide on that, right? There's no way to tell pathological. They will look exactly identical, right? But I think it's good to say renal limited TMA because the etiologies are identical to systemic TMA with renal involvement. And consequently, the idea is that if you do not give a complement inhibitor in a patient with suspected AHUS, you are denying them therapy. So I think from a pathology standpoint, it'll be nice if you think it's TMA, just to call it TMA and say and leave it to the clinician to, and we would do exactly the same, discovery in terms of labs and even genetic testing in such patients, right? In the absence of a known etiology. So in the patient that Yoni just presented, if you say that there's signs of TMA, and in malignant hypertension, you don't see fibrin commonly, right? You see a lot of onion skinning and damage to the vessels, but you see a lot of fibrin, for example, in the glomerulus and in the arterioles. That's highly suggestive of that it's not just malignant hypertension. One should be looking for other etiologies.
Great. Well, and we're at time. Jay, thank you so much for coming.
Thanks for the opportunity. I wish I could come, but
opportunity, yeah. I'm sure we'll see each other soon. But thanks everyone for coming out. And yeah, we all learned a lot. Thank you so much.
Okay. Bye everyone.
Bye-bye.
All right.